All right, hello everyone and welcome. I'm so happy to see everyone here today. So welcome to our breakout session. To kick off the session, for those of you who are logged in, if you don't mind, I would like to ask for participants to turn on your cameras if you are able to. That helps facilitate discussion and so we can see each other and see our expressions. So my name is Janae Beer, and I am your moderator today. I also happen to be an awardee from the U.S. National Academy of Medicine. My project is a new statewide telehealth model to deliver dementia teleassessment and tailored care planning to older adults in low-access rural areas. So I'll certainly be speaking up throughout this session about my own experience, but I'm absolutely thrilled and excited to welcome a number of speakers to this event today. So we have Mariela Gate-Reyes, who has been funded from the National Agency for Research and Development of Chile. We also have Atif Adam, who is also awarded from the National Academy of Medicine. These two speakers will be telling everyone a bit about their projects, what they've accomplished, and how their seed funding has made it all possible. So in terms of format today, the awardees will again talk a bit about their innovation journey. So I will turn to the volunteers to introduce themselves here in just a moment. And what I would like is for each awardee to speak 5 to 7 minutes, give an overview of your project, and then we'll open up for discussion. So I encourage everybody here attending to please feel free to pipe up and ask questions. You may unmute and speak up, introduce yourself when you ask a question, or you can certainly put questions in the chat and I'll be monitoring the chat as well. All right, so to get started, Mariela, may you please take it away?
Thank you, Janae. Thanks. I'll need the slides, please. Well, it is a great pleasure for me to be speaking today presenting the project entitled A Lifetime Home, an Intergenerational Accessible Social Housing Model. Next, please. I am the director of the project, and our team is composed by 5 researchers, Javier Acevedo Lopez, Paul Honeyman, Paulino Osorio, and Gabriel Felmer, and we are 2021 Catalyst Awardees funded by ANID, the National Agency for Research and Development of Chile. Next, please. The aim of our project was to create an intergenerational accessible social housing model. Next, please. The problem it's addressing is the following. Older people from lower income backgrounds in Chile frequently live in social housing. Usually, inadequate housing conditions hinder their mobility and activities of daily living, affecting autonomy, and this situation forces them to make the decision to leave their homes. In response to this, we have created the intergenerational accessible social housing model that is adaptable to the changes that people experience throughout the aging process, promoting permanence in their homes for as long as possible, independently of the level of ability and household composition. This contributes to preserving their mobility, functionality, social connectedness, sense of place, and staying active in their communities, thus extending their life quality. Next, please. How do we came up with the idea? So the idea is inspired by the Lifetime Home Standard that I got to know while I was doing my PhD in the UK. The Lifetime Home concept is based on 5 principles: inclusivity, accessibility, adaptability, sustainability, and good value. Also, together with Javier Acevedo, we conducted 2 previous studies on disability, social housing, and access. And we developed a set of recommendations for access in the home that we are testing, or we would like to test in the project. Next, please. Well, the idea, why is it innovative? Well, it seeks to challenge the existing Chilean social housing paradigm, because at the moment we have here like 2 types of dwellings, one for the general population and one for people with disabilities. However, the latter only considers the access needs for wheelchair users, and none of them really is adaptable to the changes that occur throughout the life course. So our idea is potentially transformative, as it envisages a social housing paradigm that develops a unique dwelling that promotes the permanence of people for their lifetime in their home. Also include ultrasonic technology and accessible features for people with visual and hearing impairments. Next, please. The innovation is achieved through different indicators. The first one is modularity in design. So we put forward an adaptable modular housing design with an off-site construction method that allows for a number of domestic spaces to increase and decrease in an easy way, cost-efficient, speedy manner, allowing spatial transformation according to the intergenerational needs. So those are the models, and we did a study of the space needed for a wheelchair user there. Next, please. So this is the minimum area layout. That is a home for 5 people, and considers the needs of a manual wheelchair user and the need of a storage space that usually in social housing in Chile is not considered. Next, please. And then this dwelling can be expanded to accommodate the needs of a neurological wheelchair user. And then with the modular system that we have created, we have the possibility to add some modules and have some more rooms as well. Next, please. It works like that. This is the mobile, the system for mobile walls. Within the same structure, we can add 20 square meters. Next, please. And then another innovation is the adaptability of fixtures and fittings with electromechanical mechanisms that allow movement and adaptation to the user. So usually when people who can walk, usually they cook standing up. But for people using wheelchairs, this is difficult. So that's why we, created this mechanism so people in the dwelling can cook standing up or sitting down. Next, please. We have here the fitted wardrobes with shelves with rotating systems, and then the kitchen and sink with mechanical systems too. Next, please. We have also home automation for lighting, temperature and sound sensor, control of elements through voice, commands, and food switches. Next, please. In relation to sustainability, we have green roofs, windows with photovoltaic glasses for saving energy, a grey water recycling system for washing machine use, exterior green walls, and foundations that reduce the use of concrete, respecting the natural topography of the site. Next, please. Next, please. How is unique and how it addresses the gaps in the field? Well, it has the principles that we, these principles is accessible, using technology, intergenerational, that meets the different and changing needs of different households, is transformable because we can increase and decrease the number of rooms and size of the rooms and meet the local socioeconomical variable, and is environmentally friendly. Next, please. The target image is that one, is a working image. Next, please. Then the results and successes. Well, one of the successes and the result is the accomplishment of the indicators that I showed up before, and the building process is progressing. And then the success of the strategy to obtain donations from private companies that produce building materials is reflected in the number of companies we have on board so far. Next, please. This is the building process. You can go along. Next. Next, 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 please, and next. So challenges and lessons learned, we had a lot. We have had, we are in the process of building, and it has been very difficult because Well, a lot of things are out of our control, such as times and administrative process of the beneficiary institution, weather that has affected the building process, time taken to get the materials, which affected the building schedule. We depended mostly on private donations for the materials. Then the COVID pandemics. Of course, we had quarantines due to illness of the members of the research and building team. I think all of us have been ill at some point or twice. The scarcity and elevated cost of building materials due to COVID-19 pandemic. So the lesson learned is taking into consideration all these factors when building a one-to-one housing prototype. Next, please. Next steps and future directions. Well, we have devised a testing strategy to assess the accessibility features of the prototype as well as its technology. So when we test the model, we are going to do potential adjustments. But at this point, we really need more funding for the team to continue building the dwelling, for prototyping and testing fittings, furniture and appliances design, and to buy materials that have not been provided by private collaborators so far. You can see there the technical testing that we are doing, the motor for vertical movement mechanism of countertops, and then the preparation material to test accessibility and adaptability of domestic spaces with different types of families. We are going to do a qualitative study. And the last one, but not least important, please, next, is the building, the team, sorry. So the researchers, the professionals, and the support staff, because we are really a team. We wouldn't be able to do what we are doing. So we are very, all of us, and especially the support staff, are very important. So thank you very much.
Mariela, thank you so much. What an amazing program. I have about 1,000 questions for you, but I'm going to hold on that. So that way we give Atif a chance to talk about his project, and then I'll propose questions for both of you. But thank you so much for sharing. All right, so now we can shift over to Atif Adam, who is also joined by Caroline, Sigala. So the two of you can take it away.
Thank you, and that was a great talk, Mariela. I also have a bunch of questions, but I'll hold off till the end as well. It's great to meet everyone. I'm speaking on behalf of Dr. Dean Sherzai and Dr. Aisha Sherzai, who are mid-flight coming back from Spain, and the flights were delayed, so they aren't able to make it in person. So hopefully me and Caroline are a decent replacement. But great to meet everyone. I'm Atif Adam. I'm the Chief Development Officer with Healthy Mind Initiative. We also have Caroline Segalia, who's a Chief Coordinator. Dr. Sherzai is the CEO, and he is a neurologist, and Dr. Aisha Sherzai is also a vascular neurologist. So this project, the Healthy Minds Initiative, is a community-based lifestyle intervention. And if you look at the spectrum of aging-related or Alzheimer's-related interventions, community-based lifestyle interventions can prevent more than 60% of the burden if planned early. But a lot of these interventions tend not to reach minority communities in the United States. The current healthcare model for Alzheimer's disease is predominantly still hospital focused. So when lifestyle interventions are applied, they take place in clinics and hospitals, which have consistently failed to embrace, especially communities such as the refugee community and the African American communities. Thus, while more than 6.2 million individuals live with Alzheimer's in the United States, African American individuals have a 2 to 3% higher risk overall compared to non-Hispanic whites. So when we really started this project with Dr. Sherzai and Aisha, the goal was threefold. One was, how do you understand the needs, especially in these minority communities, when it comes to aging-related diseases? How do you embrace existing community structures and existing models of care that already exist? And how do you build a sustainable model where the communities can take ownership of the interventions themselves? So the Healthy Minds Initiative really kind of struck out in building out of a program that Dr. Sherzai and Aisha had, which is the Neuro Protocol, which focuses on nutrition, exercise, relaxation, sleep, and optimal cognitive activity. This is a well-established program that Dr. Shahzai and Aisha have built out. It's run through multiple clinical trials, and again, has been predominantly focused within the hospital setting and the non-Hispanic white American population. So as we came into the African American community, one of the key things that we started off was establishing a community partner. So we worked with the African American Church Consortium, which was a group that had over 24 churches that had really involved older American populations, especially in the Southern California region. So what we worked with them was identifying key champions, both to take ownership of the project itself, but to really understand the needs of the community as the project scaled. So one of the key things we defined were 4 different roles: a chapter leader, this is a liaison at the church who would work closely with our team; a director of development, basically a person already identified within the church to help fundraise and work with the organizational logistics. We also, because the project's really grounded on research, we wanted these communities to take ownership of working with us on the research aspect itself. So as we had a large CBPR component, the couple of church members who initiated and started working with us not only in identifying areas of research need, but how do we get the research results back into the community? And lastly, someone to handle the marketing and the coordination of these efforts. So as this project scaled out, one of the key things that we realized was the involvement of these communities doesn't really restrict out into the people, the community members who have Alzheimer's. We really needed to bring in the whole family itself. So in addition to expanding onto folks with aging-related diseases, a large aspect of this community-based focus was really involving the caregivers and families itself. Something else that we really learned was, in addition to taking a CBPR approach, what we really focused on was building an agile, product-centric approach. Something that was focused on in the beginning was the idea of human-centered design. And the goal of this project, as we came out from this funding source, was to stay away from sticking to a technology or sticking to a specific need. The goal of HMI was to see how these communities could adhere to some of the activities and plans that we had in place, what kind of methodology would be useful to a specific community, be it an app, be it online Facebook forums, or be it a Neuroverse course. Keeping the flexibility agile and keeping the individual and the participant at the heart of this human-centered design product was key to succeeding in making sure that the reasonable adherence of this project over time could be met. The goal of this project right now is to get additional funding, and we are currently on scale to expand to 100 churches around the United States. We've also expanded to other communities, especially during the Afghan refugee crisis. We've expanded onto specific communities that have housed these refugees and replicated and scaled this model to address the needs in those communities as well. That was it from my side. Caroline, do you have anything to add there? I think you're on mute. Yeah.
Thank you very much. Thank you, Atif, for that. I'm Caroline Segala, and I was, and excuse me, I have a little bit of a cold or something, so I apologize if I sound a little bad here. But I was hired on by Healthy Minds Initiative in April of this year to work as a program coordinator, particularly with this program with the African American faith-based organization. My background is in urban planning and studies, and I've had over about 20 years of experience in community development. So I worked a lot in the public sector, helping various communities with empowering individuals and organizations, and particularly underrepresented populations. So when I found Healthy Minds Initiative, I was really happy to see that they were focusing on community and helping underrepresented communities. And touching on brain health and Alzheimer's dementia, something that's very close to my heart too, because my family has experienced that as well. What I liked about HMI is that it uses tools that are already available at a community's tools that are available at their disposal, right? It uses science, technology, research, social media, and community to address brain health. And what's unique about it with using the community-based participatory research approach is that it takes into account communities' very unique and different cultures. It takes into account their histories, their stories, or their particular dietary patterns, their exercise regimens. Everybody has a different way of relaxation. So it's, the one size fits all health approach or brain health approach that current healthcare has. It's not working. So this particular concept, I think, is very innovative. And I think that it will get to the heart of the matter. Just to add, the other things I think that also makes our program stand out too in working with the African American faith-based organizations is that HMI is about trust, inclusivity, and community. So it's definitely a grassroots approach, and it's inviting communities to participate in developing brain health prevention program, taking into consideration, like I said, their unique culture and background when developing lifestyle interventions that resonate with them. And the coach program and the chef program that's also part of this is led by their peers. So it's actually people they recognize and people they trust from within their community. So I think all those things are so important in addressing the underrepresented communities that are currently not represented properly by healthcare. So I think we kind of fill that gap to address brain health prevention for those that are most impacted by Alzheimer's dementia that are not properly represented in the healthcare system. So we were really fortunate to have been awarded this generous award by NAM and proceeding with working with the African American faith-based organization. One thing that we have, we've already seen some successes with some of the interventions that have been created. There has been positive feedback from the participants. One thing, because of the age cohort, is that some of the older population doesn't have access to technology sometimes, or they don't know how to utilize certain devices. So we're, trying to address that challenge with either providing the devices or perhaps creating definite instructional videos and one-on-one communications with these individuals so that we can reach them all, since a lot of this is all done online. But anyway, it's looking really promising, and I'm really happy to be part of this. It means a lot, and it's affecting all of humanity. So I think it's important that we all work together on this. And thank you so much for having us here today.
Mariella, Atif, Caroline, the work you're doing is absolutely incredible, and I can certainly relate to so many things that were brought up today. So some of the work, just so you know, kind of where I'm coming from and where my questions come from. I do work also with persons with dementia, and here for our center, that NAM has helped fund. We're out in rural Georgia, where health disparities related to dementia and all of the risk factors leading up to it is a huge problem. But also housing comes up a lot when we're out in rural Georgia, talking to folks about aging and sustainability and lifelong health. All of these same themes are often brought up as we're doing community-based research out in rural Georgia. And similarly, we're working with faith-based leaders looking at, the potential of telehealth in places like churches and libraries and other accessible areas in these small communities to help connect them with resources here at our university. So much of what you all brought up it definitely rung with me. And one thing I kept kind of hearing from all of you, these projects have been going on during an incredibly difficult time, right, with COVID and everything else happening. And one thing I kept hearing from all of you was, mentions of your team, and that's very much the case for our team as well. We were a close-knit group and really had to pivot and overcome some incredible difficulties to get the project going. So my first question for all of you, given COVID, everything that's been going on the past few years, what have been, or maybe one or two examples of kind of your greatest pivots, and how did that make your team potentially stronger, or even put, some challenges on your team that you had to then rethink and overcome?
I can go first.
Sure.
As So I think one of the greatest challenges working in these settings where relationships are a key is working through virtual relationships, that now you don't have people in front of you all the time, but you have to kind of have a camera and have this artificial connection that you have online, which takes a shift. I mean, it seems like it's a lot more time efficient, but at the end, it tends to be stressful when you're trying to navigate speaking over other people, trying to get your ideas across. So I think kind of re-identifying what those nuances are was critical. This is just internally. I think the other thing that we had to quickly learn was how people are comfortable interacting in the real world as well. You can't have the same spaces, you can't have large get-togethers, especially because we were focusing around the African American churches. There was early on in the pandemic, you couldn't really have large gatherings, and a lot of the connections that we relied on were starting to shift into more these siloed gatherings at home brought together by virtual communities. So we really had to kind of keep the momentum going. How do we keep people connected? And we shifted from, we really want people to continue understanding that some of these activities that you do in person in groups could also be done virtually. So pivoting to more online forums, having classes that Dr. Aisha Shahzai shared online. So kind of understanding what that shift is and what the caveats of that shift is, both in terms of technology uptake, comfortability, internet access. So it took a bit of a learning curve. And now I think we are kind of in this process of, is a hybrid model, people who like that extreme of online, people who don't like it, and some people who like a bit of both. So for us, it was really understanding that relationship piece and keeping and strengthening the core aspects while learning to modify and adapt things that change based on just social gathering constraints.
Yeah, Atif, that's really insightful. We had a similar experience with our team where we ended up going with a hybrid approach, where we're out in rural Georgia. We work with 4 communities in depth, and we're there monthly. And yeah, we have a hybrid of some in person, some online, and we've had to adjust our communication style, but also communication frequency a good bit because of that online feeling a little out of touch. We had to think about other modes of communication, email updates, newsletters, that sort of thing, to keep people feeling connected. But that hybrid ended up actually, for the most part, working. Mariella, how about you?
Yeah, in our case, I think, well, we could, do the hybrid approach for the design of the, when we were working in the design of the prototype. However, though, when it came to building, it was impossible to do that. So we had to be patient, so we had these rules. So if anyone had symptoms, so they had to stay at home, and of course that affected the times. And I think that we are, we expected to have more advance by now, but it was impossible. And also, because of the COVID pandemics, the prices of the materials and the availability of the materials is really complex. So I think that, that really put pressure on us. But I think that because of the, the commitment of the team, we have been able to progress. So I think that, that's what I really spend a little bit of time in the last slide, because I think it's important to recognize the work. We are like about 25 people working in the different parts of the design and building process.
Fantastic. I have a question here from the audience regarding the constructs of social equity, or maybe even stigma. If each of you could maybe talk about how that has played a role in your project and the innovation that you're putting forward.
That was for me?
Oh, sorry, addressing social equality, stigma. These are things that your team is kind of, hitting the nail on the head. And so if you could talk a little bit about, what you're up against as you're trying to, move these projects forward in terms of breaking that down.
Yeah, well, I think that in our case, because, our design is supposed to be intergenerational, and we are developing this model. So we expect that in the future, we won't have houses for disabled people or older people. At the moment, we have something that is called condominio de vivienda tutelada, which are housing projects for older people. But, that is not really, it's like all people together, a group in a housing complex. And we expect that, with the project, with this idea, we are going to be able to have people from all ages living together, and that the building will accommodate to their needs as they age. And also, you can add more rooms. There is a phenomenon here in Chile that is called allegamiento. That means that, and especially with the pandemics, that was accentuated, where, for instance, some people, in like lower income background people, usually, the like grown up children, they go back together to live with the parents. And hopefully, this dwelling will be able to adapt to that changes as well. So adding more modules. So that's why the construction system is modular.
And so your construction system is modular, and that was really interesting to see. And you had a bit on your slide, looking at like some of the next steps will be looking at fixtures and all of the interiors, I guess. Do you have any insights in terms of, what approach you might take to universal design as you're putting in fixtures and furniture, and you have a lot of stakeholders to make happy, right? Older folks and younger folks, they all might have different opinions. So how might you tackle that?
Yeah, well, universal design, the idea is to try and do like an inclusive design approach.
Inclusive design, okay.
Inclusive design, because universal is really big and is impossible to really cater for the needs of everyone. However, the idea is like, because you can like change the heights of the countertops and things like that. And we are also trying that out in the say bathrooms and, the fixtures and fittings there. So the idea is like with home automation, we could transform to cater to the needs of the households.
And doing it in such a way where it doesn't feel too medical, right? One thing
Exactly.
we hear from folks who are designing for aging in place or taking into account disability, I want it to look good, but also be functional, and maybe that's kind of the sweet spot for inclusive.
Yeah, absolutely. Yeah. Thank you.
Atif, I don't want to miss we kind of got off in talking about inclusive design. So going back to the original audience question, the question was regarding, concepts of social equality, stigma, well-being in your work. And certainly when we're talking about dementia, when we're talking about African American communities who have been, marginalized and included or excluded often from research opportunities or even taken advantage of. How are you addressing that in your own research, in particular, your community-based approach?
Something that we started off really early was understanding the culture and concept of aging within these communities. I think being a physician myself, it's easy to go in and say, I have the solution and I'll fix it. So that's how that's how we're taught to do things and you get paid for it. It's really hard to tailor needs, which means that it takes time, it takes effort. So something we were very cognizant of was understanding the culture, the existing relationships, and I keep coming back to the word relationships because it's key to the work that we're doing. Seeing how the community really understands, supports, and builds around the idea of aging as a community structure. So as we went in, our initial CBPR qualitative reviews wasn't really understanding what Alzheimer's meant. It was really understanding what aging meant. And we really, from our research perspective, we took the approach at different levels, at the individual level, at the community family level, at the health system level, and the policy level, because the goal of building a scalable and sustainable aging intervention solution really requires all those concepts. You need to have an understanding of what individual risks for aging are, especially for Alzheimer's. Where does the community and family needs and support come from? What do the existing health systems availability in terms of resources, insurance, etc., come in? And from a policy perspective, be it regional in terms of transportation or green space access to simple things as housing, as well as funding sources. So from an equitable distribution of resources, we all took up different pieces to see how do we build this at scale, not all at the same time, of course, but the goal was to build evidence that something sustainable could be used and scaled across different levels, and at what key component do you need that additional piece in. Like once you had 12 African American churches really tackling this program, the next step for us was to integrate this with key health systems in the area, identify their needs, create that forward structure, and use that evidence to really structure policies for that region. So from a social equity stigma perspective, I think the goal has been to really identify the needs of the community itself, build strengths and resources and evidence, and scale that evidence to each of these different levels that I talked about.
Yeah, Tiff, you bring up a lot of really good points, things that our team has a counter to in working with communities. Community-based research, one thing we convey to our students here is it's extensive training and practice of going into these communities with cultural humility, right? The assumption we know nothing. Sure, we're experts in our field, but we are not experts of that community. We are not experts of knowing that community's strengths and how to best leverage those strengths, right? So it sounds like a very similar process of really understanding that community, listening, not making assumptions, right? And then building a plan with them. And Tiff, it sounds like you're really working with the community, not for the community, but with the community and developing that action plan. So that way you're meeting them kind of in the middle, and they own part of it too then, right? They're just as invested as you.
Yeah, and one of the key things I think for CBPR, because I'm a system scientist in general, one of the key deterrents is speed. People feel working with CBPR, qualitative data with people, you're sacrificing efficiency for speed because things have to be slow, things have to get things in place. And I think something we've really talked through is how do you build a product-centric approach. I keep going back to product because that's how we've taken it. It's a very agile system. We reiterate the flow every single time. It's almost a community-based business model. And the reason we want to do it that way is because the goal of this isn't to have consistent handouts. And I'm not saying handouts from grants or whatever, those are needs, but I think the goal of this is to show efficient needs, efficient successes, and use that agile structure to build a sustainable financial as well as health pathway for these communities and other communities. And that can be done without sacrificing speed or efficiency.
Yeah, boy, lessons learned there, right? You know, I mean, hearing you speak, I never would have linked community-based research with words like agile or then whenever I think agile, I also think of rapid prototyping, and you know, those things in the community often aren't as fast, but it sounds like you've figured out how to kind of find that balance almost. Mm-hmm. Fantastic. So I'm going to pause a moment. We have a lot of amazing expertise here in the room with us. I see a few videos on, a few videos off, but for those of you who are logged in, please feel free to unmute if you have a question and ask our speakers. And I'm a professor, so I can sit here in silence for a while until somebody speaks.
I guess I could go ahead and say something. So my name is Jack. I'm the Catalyst Award winner for 2022. And my background is actually in human-computer interaction. So I come from an engineering background, and I learned human-computer interaction where I got fascinated about combining technology with humanity and other design-related methodology. And this year, my winning proposal is about using new technology to envision elderly's transportation issues. And I studied in the USA. I worked in the USA, and right now I work in Taiwan. So, but the reason why I joined this breakout session is I know, although I have an engineering background, I know this social science category is the platform for people to share their needs or their observations about humans. And I think that's where a lot of new projects or new insights are observed or generated. So I mean, if I chose the data and science group, I think I will hear a lot of technological advancements, but that's not really what I aspire to study right now. And I heard your talks about housing, so community, which were very fascinating to me, because my award-winning project, my winning project is going to about transportation and how people, how aged people use current emerging technology, AI, self-driving cars, or even intelligent roads to transform their lives. And where I proposed my studies for first year, I'm actually going to conduct a lot of design workshops to see how the elderly in my Taiwanese community will rethink and think about their current transportation needs. So this is who I am, what I'm going to do for my award, for my proposal. And I'm not sure if this aligns with the theme of this group, but I hope I get more insights or even mentoring from all of you, because I'm really new to this healthy longevity community, but I really enjoyed it. I attended the Global Summit last year, and a few months later I applied and I got awarded. Now this year I'm going to be announced as one of the winners. So this has been a really rewarding journey to me. So I look forward to your suggestions or mentors. Thank you.
Thank you, Jack, and congratulations on being awarded. I can speak a little bit to what you were mentioning. You said human-computer interaction. My background is actually in human factors. I'm an engineering psychologist, so very much a related field, and I work a lot in human-computer interaction. And, you know, as you're talking about transportation, you know, and Tiff, you might even have some thoughts on this. You know, one thing I've encountered when I've been doing community work with regard to transportation and healthcare, I've heard stories of older adults in rural areas where they have a lack of access to specialty care. So they rely on either public transit or maybe even arranging for someone to come and take them to their specialty appointment. I've heard on more than one occasion where an appointment is made. There's here in Georgia, we have an extreme lack of availability of specialty care for diagnosis for dementia. So there's 6 months to a year waiting list to get screened and start the diagnosis process here, which is terrible. But folks will schedule their ride. The day will come. They are at their assisted living facility waiting for the ride to come. It doesn't come, then they have to call, reschedule, and they're in the queue all over again, another 6-month wait. And that is an incredibly long time for a person with dementia. They can progress significantly in that time period. And so, yeah, some folks here, you know, have been talking a good bit about, well, how do we, you know, kind of innovate transportation itself, right? And addressing this incredible access issue. And one thing that we come across for on the human side, right, is, well, are those autonomous cars reliable? Can I trust them, right? And so there's that whole human element of technology adoption. And you know, Jack, in your work, maybe one thing to think about would be technology acceptance models that look at, you know, there are kind of two variables that contribute to whether or not a person is willing to adopt technology. It has to be useful to them, and I think that usefulness is definitely there. And there has to be ease of use and a certain comfort level of using technology. And that might be a hard sell for some older adults, especially when you're talking about such advanced systems like you are. Tiff, I know you mentioned this as well, you know, in terms of technology innovations for older adults, that you've had to overcome some technology use barriers, right? And so I'm curious, Tiff, how you might have addressed that in your own team. Obviously different than autonomous cars, but nonetheless, I think there's probably some good lessons learned.
Yeah, and congrats again. Congrats again, Jack. I'm happy to learn more. And this is a perspective from my work at Hopkins, working in digital technology and Alzheimer's, and also the work at HMI. So for transportation, at least I think of it as 3 different modalities. There's transportation as a physical modality itself, like getting into the car, just like Janae said, or the vehicle, getting to the point of where you need to. So how does that experience of being in that account for? The second thing about transportation, especially in this population, is the autonomy and risk that comes with it. Depending on the type of population you're speaking about, transportation can mean different things. And the risk and the comfort that go into it are very different for a person who has recently had a fall versus someone who is okay going anywhere. The last thing is, transportation is a process. Like Janae mentioned, her pipeline was getting into the hospital. All those events or milestones in that account for different caveats and things that can fall through, so your whole model can completely fail. So understanding the process of where this fits into the needs and what kinds of homogeneous personas you have that build around those needs would make your transportation model really successful. And going back to HMI, what we really kind of tackled was, it doesn't matter if you're on an iPhone, or Android, or a computer. If the font of the app is too small, no one's going to use it. So I think it really comes down to the minimal viable experience that someone wants with your technology. And if they're comfortable with it, and especially older populations, for some reason, they have a very low threshold for failure in a technology. If the app doesn't work the first time, that's it. It's the worst app out there.
Trust plummet. And it's hard to regain unless you have sometimes you can leverage family or other trusted people to bring them back. But
so you need to build not for what you want to do at the final, like the top of the mountain. You need to think of this as building small base camps in your mountain as you go up, and get successes and trust and build trust above. As you build trust, your threshold for failure and acceptance improves as well.
Great. Caroline, I see you're raising your hand.
Yeah, I was going to say, I see a marriage here between Jack's idea and Mariella's idea when you have the, but I think that one thing too, that, and on all this is fabulous information. So thank you so much for all the hard work that you're all doing and involved in. I think the intergenerational component is also something that's key. And I think with Healthy Minds Initiative, because it's including the entire community in the process, that you're going to have people of different ages as well. Because, for example, in the churches, there's the younger group that is more savvy with technology. So you can invite them to participate in that program to help the elders utilizing the technology. So it's basically using tools that are at the community's disposal, and just kind of figuring out a way of how to making it resonate with them, with their uniqueness. And then, as Atif said, they take ownership, and then it becomes a lifestyle. So it's not just something that you're just going to do 1 week. You want to try to you brush your teeth every day, so you're going to focus on brain health every day. So it's changing the idea of how we approach brain health, and not waiting till the end, but why not just incorporate it now? And one part too is like social media. I know this kind of goes back to the first question too, was that during the pandemic, a lot of people went more social. I mean, my mother's even doing social media, so that's a miracle in itself. But I think that it kind of opened the door for us to be able to reach more people that way, but also find ways to deliver more personalized messages to people, because you don't have the access to the human touch, which is so important. But so you have to almost create verbiage that does that in a way. But anyhow, so thank you very much.
Caroline, thank you. Mariella, I know you had something to contribute as well.
Yeah, thank you. Yeah, it's very interesting, Jack. Thank you very much for your overview. Yes, just, I mean, I was thinking about how have you thought about overcoming the technology barrier? I don't know if you have an idea, but also I think that we have, with the intergenerational approach, as Caroline says, I think that we have to question the concept of autonomy and independence, because we are all interdependent. So, yeah, I don't know, Jack, how do you do that?
So, but before I respond to you, I'm so grateful that this global summit has like a replay feature, so I can remember your names, because you are already serving as my advisory board for this project. I'm really grateful for this, because this project just started, and for all the things you mentioned, like intergeneration gaps or different kind of communities. I think there's a lot of things we have to study or explore. But to be frank, frankly, this project has just started because we have to go through a lot of logistics so we can get the money to be transferred to my institution, and that's a lot of red tape work. But one thing I can share is, so far, based on my literature or the people I've preliminarily talked to, is the thing about housing or transportation is that it's a very interesting but also challenging topic because it's very location or region specific. So one of my friends is in New York. They have their own transportation system. But another friend just shared with me that in Arizona, it's sometimes they get snow or sometimes they get very hot days. And all of those affects how they schedule or use transportation. And like currently, I'm in Taiwan. We have a different infrastructure for transportation. And I studied and worked in North America and for many years, and that's another different story. So I think it's very important that we study something that's somewhat we can generate some knowledge that's generalizable, but in the meantime, it can be individualized for certain regions, needs, specific needs of the population community. And to balance such knowledge generation, I think that relies on another.
Oh, Jack, I think you froze. If you can hear me, thank you so much for your comments. I like the mention of generalizability and certainly lessons learned across these projects, right? And we're starting to see links between these projects, and that is incredibly exciting. I do want to mention we only have a couple minutes left. And so, Kirk, I see that you have your hand up, and if you don't mind, this will be the last question.
Okay. I'm Kirk Wolford. I'm also one of the new Catalyst Award winners.
Congratulations.
Thanks. My project is looking specifically at walking and how do we encourage people to walk, and using a couple different approaches. One, to help people find green, accessible areas around them. The other is to look at what's changing in the environment and use that as a way to get people out of the house. But I wonder at times how much I'm trying to solve a Northern Hemisphere issue and a temperate Northern Hemisphere issue, or whether or not it's an issue across the entire world. So, like I said, specifically looking at here in the UK, we have a lot of variation in seasons. Also, I'm actually from New Hampshire, so I grew up in the States, where we also have big variation in the seasons. And we're trying to use that as a way of encouraging people to get out and see what's changing from time to time. So it looks like something new is happening every time they go outside. But is that so much of an issue in other parts of the world?
And I can jump in there, Kirk. I've done a bit of work on walkable spaces in the Middle East and the United States. And you're right. It's a geographical contextual issue when it comes to walkability, right? There's the building green spaces doesn't mean people will walk. A lot of the green space movement that's growing up in the Middle East, because I'm originally from Abu Dhabi, UAE, so there's a lot of ideas around parks and open spaces, but the culture and the temperature, which hits about 40 degrees most of the, sometimes the year, doesn't make it accessible to walk. And that's even worse as you grow older. A lot of these spaces also come at areas where there's a clear cultural and socioeconomic divide. You really don't find these spaces in areas where there's your middle and low income population. These tend to be touristy, high income places where your regular population does not go into. So those are one of the issues that we clearly identified. There's a difference between urban planning and architecture, where there is consistent amount of funding in certain parts of the world, but where it comes to having a cultural behavioral shift, as well as in identifying where these spaces could be potentially useful for the population who need it, are sometimes not in the same conversation. The people conversing aren't the right people who should be giving those answers.
May I say something about that? In Chile, for instance, we do have 4 seasons. So, of course, in the winter it's more difficult for older people, for instance, to go out and walk. But also we have differences between higher income and lower income neighborhoods. related to accessibility, but also to security. So it's more difficult, perhaps, probably it's more difficult to walk, to go out and walk in places that are less accessible. Yeah.
I just wanted to say one thing to think about with walking is to maybe piggyback on that and incorporate some other concepts. Like when I worked in Maine, which can get very cold too, we included things like there's this program called Museum in the Streets. So it actually used the architecture of the area to motivate people or get them enthused about walking and learning about the history of their community. So they're walking without really thinking about it. And another one is maybe, people incorporate art and then create mapping of some type to encourage the people to walk and look at the different art installations that perhaps change during the seasons, or guiding them towards an area that promotes interactions with their community members. So there's a destination component. So maybe just incorporating little things like tweaking it a little bit like that will get more people out. You create the infrastructure, but then create what will get them enthusiastic about, wanting to take that walk, and then changing it up a little bit. And with social media now, you can do so much on your phones and apps and whatnot. So just putting it out there.
Lots of innovative thought. I hate to cut this off, but we are at time. But I just want to thank everyone for your thoughts, your feedback, your questions. This was a wonderful breakout session, and thank you for our presenters, and congratulations for those of you on the call who are new awardees.